Hi, my name is Natalie Weston. I'm a second-year medical student at Dell Medical School at the University of Texas, and today I'm going to be presenting a case of sudden onset bilateral hearing loss in a patient with presumed Chlamydia Pneumoniae and Psittaci co-infection in the context of delayed hospital discharge despite rapid respiratory symptomatic improvement. A 64-year-old woman with a past medical history of hypertension, type 2 diabetes, hyperlipidemia, overactive bladder, tobacco abuse, and extensive exotic bird ownership presented to the hospital with a 2-week history of increasing dyspnea on exertion and a 5-day history of acute onset, non-painful bilateral hearing loss. Bilateral middle ear mucoid effusions were identified on physical exam. Blood analysis showed some signs of inflammation, including neutrophilia and elevated CRP. Chest CT showed significant abnormality with widespread centrilobular lung nodules, some solid and some ground glass, as shown in Figure 1. Head MRI showed extensive bilateral mastoid opacification. Viral and bacterial serology of nasopharyngeal swab, blood, and CSF, including testing for COVID-19, was negative. Upon admission, the patient was started on azithromycin and ceftriaxone and saw complete resolution of respiratory symptoms by the second day of her hospital course. Insufflation was performed on day 4 of the hospital stay, and the patient reported restoration of her hearing to 50% of normal function. As the patient kept over 20 exotic birds as household pets, and sudden sensory neural hearing loss associated with Chlamydia Psittaci infection had been reported in the literature, a chlamydia antibody panel was ordered on day 4 of the hospital course. The antibody panel had to be sent to an outside facility for testing, so the patient was discharged the same day with a presumed diagnosis of psittacosis, with plans to be later called with the test results. The chlamydia antibody panel returned positive for Chlamydia pneumoniae and could not exclude Chlamydia psittaci due to the potential serological cross-reactions. Patients presenting in 2020 with worsening dyspnea and ground glass nodules on chest imaging require rule-out of COVID-19 before other pathologies are explored. While this patient tested negative for COVID-19 at the time of admission, the chlamydia antibody panel was not ordered until day 4 of the hospital course due to concerns stemming from other potential pathologies, including a false negative COVID-19 test. And though Chlamydia pneumoniae had also been associated with sudden hearing loss in the literature, it was not a part of the differential diagnosis. Had testing for Chlamydia psittaci not been a part of a broader chlamydia antibody panel, it is likely a diagnosis of Chlamydia pneumoniae would not have been made. This case emphasizes the dangers of availability bias in relation to the COVID-19 pandemic and anchoring on a patient's social history. Thank you.